This is going to be kind of repeat or review of what we planned for treatment of CTO, so chronic total occlusions. I'm sorry. Well, successful recanalization of an occlusion requires to cross the occlusion during the procedure and to keep the artery patent on long term. Well, for crossing the occlusion, we need some experience and medical devices and some strategy. And to keep the artery patent on long term, we need, again, devices like balloons or stents and etc. So I will talk more about recanalization process. When we talk about critical limb ischemia or patients with a diabetic foot ulcer, we're talking about extensive peripheral artery disease and more distal type and more occlusions than stenosis. We talk about angiosome concept. I will just skip those. There are some factors that we should know, we should be aware of to cross an occlusion. Some knowledge on arterial anatomy, nature of occlusion, in which case most are atherosclerosis, location of occlusion, presence of a stump before the occlusion, calcification is important, especially in case of diabetic patients, length of occlusion, and route of planned recanalization. So to cross an occlusion, we need some devices. Guide wires historically has been the most important tool for us to cross an occlusion. But now we have support catheters or crossing catheters. These are stiff 2 French or 3 French catheters that support us to advance the guide wires. And now we have occlusion crossing devices. The crosser device uses vibration to cross the occlusion. Excimer laser uses laser energy to vapor the clot in the atheromatous plaque. And RF ablation, that I don't have any experience, uses RF ablation to cross the tight occlusions. These are just to cross the occlusion. We need to know about the access to the artery. It is actually told a lot today in the previous sections. We have standard roads like brachial artery road or antegrade or retrograde femoral artery roads, but we know that there are many other roads that we can use. Some or most are very safe, but we should know something about them. As I previously said, we have shown that in the common iliac artery occlusions, we shown that the antegrade recanalization had higher technical success than retrograde one. So there is some difference between antegrade and retrograde recanalization using standard guide wires. But we don't know the thing on the femoral artery or the crural arteries, but we know that if we fail with the antegrade route, we will succeed in most cases from the retrograde route, but there is no comparative studies yet. So let's talk about superficial femoral artery canalization a little bit. When we deal with short occlusions, it is good to stay transluminal and not subintimal. Both are same on long term, we know that, but when you go subintimal, you may not fall into the lumen. So that is a disadvantage. To stay transluminal is usually harder than to stay in the subintimal space, and hydrophilic guide wires tend to go subintimal. And if you make a loop on a hydrophilic guide wire, it 100% goes subintimal. So when we have short occlusions, we usually use Teflon-coated floppy straight guide wires, 0.035, or low-profile guide wires. Or we can use crossing devices like cross-atherectomy device, as in this case. It is, I think, yeah, it's moving. Yeah. Here it's slowly going down. We would like to be in the lumen and not subintimal in such short stenosis. After that, we place a guide wire and make a balloon. For long Sfa lesions or complete occlusions, as I said again, subintimal is usually more rapid or more faster than going transluminal. For these, we usually, if there's a flush occlusion of the SFA, usually come from the contralateral side, use a long vascular sheath, butt the guide wire and the catheter, and then push it. We use hydrophilic guide wires all the time. There's usually a resistance when you go subintimal. When the guide wire falls into the true lumen, that resistance is lost. You feel it. And then advance the catheter, give contrast. If you're in the lumen, go ahead with balloon dilatation or stenting. This is just after PTA. If we have extensive calcification, as in this case, it is better to place stents. Even nitinol stents do not have enough radial force to keep that artery patent. If we cannot go into the lumen when we go subintimal, then you have to do something. You can use re-entry devices. This is Pioneer catheter or Outback catheter that we don't have too much experience on them. Or you can turn the patient prone position, but it's cumbersome. You will not be able to use your sheath in the common femoral artery, but this is a way to achieve the success. In some cases, such as these, if you cannot cross the contralateral femoral artery, and if the common femoral artery at the same side is occluded, we can use sometimes distal or proximal femoral artery approaches. Or again, even for femoral artery occlusions, you can come from the tibial arteries. So how about crossing an occlusion in the crural arteries? This is more important in patients with diabetic foot ulcers because many patients will have multi-segment crural artery occlusions. Some facts, revascularization of a tibial artery is preferred rather than a peroneal artery if possible. And we try to revascularize almost all arteries in the crural territory to have a good improvement of wound healing on long term. These are the basic principles. If we come from the antegrade road and we successfully recanalize and dilate the arteries, and everything is finished. But if we cannot, if we fail to go to the distal part of the lumen and cause extravasation, we should do something because many such patients will not be able to have surgery, and endovascular treatment in many of these patients are the only treatment that is available. To increase our technical success means to cross the occlusion successfully and open that artery up. This is important for the patient. So we use retrograde tibial artery approach. If one tibial artery is patent with a patent palmar arch, we can recanalize the other one using this pedal loop. Or we can puncture the tibial artery. We always use ultrasound guidance to puncture these arteries. This is not working. No problem. Okay. We almost never place sheaths. These are sheathless methods, and we can use a support catheter. This is a 3 French support catheter, or we can use a balloon catheter that's also a stiff one. We can predilate or make the final dilatation from below, from here, if the problem is just the crural arteries. This is only one of 2 cases that we had to place sheath in our early experience. We never use sheath anymore, except in cases where you need some devices. If tibial artery distally is occluded, we have a lot of Berger disease patients, and in those patients, distal tibial arteries are occluded. And when we cannot come from the antegrade, we have to puncture these occluded arteries. These are rare, but we have used ultrasound to successfully puncture these occluded tibial arteries, 7 or 8 cases at most. When we use the ultrasound and enter this lumen, we're not sure whether we are in the lumen or subintimal, but that does not matter. Just we advance the guide wire, a hydrophilic tip guide wire, a low profile guide wire, and it goes subintimal or luminal, but at the end, the guide wire will reach the popliteal artery. And from then, we can dilate the artery from the reverse side, from the antegrade approach. Sorry. In some cases, there are two subintimal pockets, and these two does not meet. And you can use your guide wire from below and hold it with a snare from above, or you can just make some different maneuvers to stay in the same lumen. These are all possible. Sorry. In only one case, we used the crosser atherectomy devices from the retrograde because we couldn't achieve to cross a tough occlusion in the proximal tibial artery. It did. Then we had to use a 5-French sheet in the tibial artery. For peroneal artery, ultrasound usually cannot be used. It is deeply located, and we have to use road mapping to puncture the peroneal artery distally. I'm sorry. Go ahead. There's a small distal peroneal artery here, yeah. Make a road map. We have recanalized the anterior tibial artery, but we would like to recanalize more because of patient situation. So under road mapping, these videos are not moving, I'm sorry, no problem. We always use 21 gauge needles and low profile hydrophilic tip guide wires. Yeah, these last series did not work. Okay. Maybe I can show this. No. I'm just skipping. We're short of time. Yeah. Well, crossing chronic total occlusion is quite challenging, especially in crural arteries, and usually requires good manipulation of guide wires or catheters, and experience is quite important. We need to know alternative things, such as alternate access sites to the artery, alternative techniques, and devices that will help crossing an occlusion safely. The devices we use may obviate the experience gained in many years, but the scientific evidence on alternate sites or crossing devices are scarce. So we need to collect data on those to have to know when to use these alternate rows or these devices. When they are perfect, we will see them. Thank you.
Thank you.